So Dr. Thomas Kelly is the co-founder and CEO of Heidi Health. And it's something that me and my colleagues have been really exploring quite a bit lately. It's AI Scribe, right? And so are these your slides? Take it away. Thank you.
Hello, everyone. So my name's Tom, and yeah, thanks for having me. I'll just quickly check slides are going to work. Yep. I just feel the energy in the room is a bit low. So I always start with all of these slides with, I just want to know who's in the room. So can you do me a favor and stand up? Stand up, stand up, stand up, stand up. Thank you. Stretch, relax. Okay. So who in the room is a clinician? You can sit down if you were a clinician or are a clinician. Sit down. Okay. If you work in strategy or innovation in the hospital or health system you work at, you can sit down. Okay, cool. If you are dealing with data analytics, pipeline, sit down. I imagine everyone will sit down. And anyone else, come find me later and tell me what you do. Sit down. So thanks for having me. That's just a useful way. You get exercise, I get to know who's here. So I'm from Heidi. I'm a doctor by background. I'm an Australian, if you can't tell, with a Canadian team here. So yeah, was a vascular surgery registrar, so was going to be a vascular surgeon, worked in hospitals for about 3.5 years. I was always very interested in AI, so before medicine I studied computer science and maths, and both pure and applied, so I learned all about analytics, data, how to use that to change my practice. And was always kind of obsessed with the idea that doctors, when they went and saw patients, they would bring some sort of AI toolkit with them to help influence their decisions, to make them not biased, to bring in data from the record just at the right moment to make sure I'm making the right decision. So this is what Heidi does. It's an AI scribe. At your organizations, who's already using an AI scribe with their clinicians? Just hands up. Okay, no, not that many. So I'll explain how it works. So basically, if I'm the clinician and I'm seeing a patient, I'll just say, hey, I use this tool, it helps me write my notes. And it will listen into the background and transcribe, so it's turning the conversation into a transcript. And then at the end, I click stop, and it instantly generates a note that I want based on my own template. Now, for everyone in the room, it can be structured, so it doesn't just have to be free text. It could be SNOMED coded, it could be ICD-9, it could have all of the relevant fields that you want to encode into the medical record. Very often, clinicians might start using it like unintegrated, just as a way to save them time. And usually when we work with an organization, we figure out how to integrate the right structured data elements back into the record. And I think for non-clinicians, which a lot of you are, you cannot believe how much time clinicians spend documenting. Now, most of you probably like that because you get the data of what they're doing, but the doctors hate it. It's the bane of their existence. It's not the reason I went into medicine to document what I'm doing. I went into medicine because I wanted to use my talents for good, figure out what's going on with the patient, come up with a plan, give them that plan, hopefully solve their symptoms or make them feel a little bit better, and then go see the next patient. My idea of medicine was my old GP who didn't have a medical record and used cue cards. And he would only write something down if he thought it was particularly interesting. So that was my inspiration. I wanted to go into medicine to be like him. And really, actually, that's the core of clinical medicine, that patient interaction. And so AI scribes are incredibly popular. Heidi's one of the most used in the world. We do more than 2.5 million visits a week, and all around the world, mainly the Commonwealth, I would say. So started in Australia, the whole of New Zealand has chosen Heidi as their AI solution across the whole country. In the UK with the NHS, and then in Canada as well, used by more than 50,000 clinicians very, very regularly. Lots of different organizations. I think I share this slide just to say that the only thing standing in the way between amazing AI tools in your organization is pretty much you and your executive teams. So you need to come up with the right way to implement it, but there's this isn't a hypothetical AI is going to transform the healthcare system. It kind of already is. It's just a matter of when you pick or want to jump on the ship. So yeah, returns lots and lots of time, lots of hours. I think practically for everyone in this room, maybe the one thing that I want you to take away from this talk is that ambient tools in particular, anything that's listening into the background, will give you literally all the data that you need. More than anything that's in the medical record, more than you capture today. Pretty much the currency of a health system is those conversations. Now, it's not 100%, so I used to be a surgeon. There are things that aren't said out loud. There are procedures, you do have to look at patients, the way they look. There are things that aren't in the sound, but most of it is. So if you want data on how much time nurses spend with certain patients and how complex they are, which of my patients, when they walk into my ED, cost me more nursing hours versus not. Well, imagine if you'd transcribed the last 5 years and I could tell you exactly how much time nurses spent with different patients based on their demographics. Or which departments in your health system have really good bedside manner versus others who don't. And whether that is correlated to outcome or not. I think it would be, but who knows? So what I really suspect is that eventually most of healthcare will be transcribed. Now, there's lots of privacy and other things which we'll talk about that are important considerations. But the benefit of having transcribed it is you get an objective record of what happened. You have literally the conversation. There's still a critical kind of clinical note, review of the notes, et cetera, that happens. But essentially, you've got that data of what actually happened. AI can transform that into any structure that you need. So if you are doing a clinical registry, it can instantly go to the registry. If you're trying to get data in from an ambulance or from some other source or a pile of pages that the patient just threw in front of you, literally today with Heidi the app, you can just take a photo of the 10 things and it will instantly transform it into exactly whatever you want in a structured form. So the utility today is like where the adoption has been with clinicians, but I suspect kind of across the whole system, like in 2030, what does it look like? Most of our interactions, even the non-clinical MDTs, meetings that we all run will be transcribed if they're not already. So maybe thinking even broader, the opportunity with AI is beyond just sort of making clinicians more efficient. It's really about trying to increase capacity. That's why we say our mission is about doubling healthcare capacity. The health system, the way it works, is this idea that I've studied for a long time, I'm a doctor, I'm the precious resource, I've got the knowledge. If someone has varicose veins, I used to be the guy, and they wait sometimes months, maybe a year. If it's bad enough, they finally get to see me. I've got to stay away from the mic. And then in that moment, I gather the history, I figure out what's going on, I give them a plan, and they move on with their lives, and I go on to the next patient. So really, the way that the system works is based on scarcity, like the scarcity of that clinical time. And this is a graph that everyone would have seen before, but the more advanced we get in medicine, the more comorbidities people have, the more kind of total clinical effort and time it takes to manage a patient. So that's an ever-increasing demand for actual caregiving, and the amount of time that you have to spend to do gold standard care is always growing. But the amount of clinicians and the amount of time they have to provide that care is very limited. It's also not free. Back to the funding models and other considerations, we can't just infinitely expand clinical time. So how do we deal with this? There's this fundamental demand-supply mismatch. And you see this all around Canada. So we did an analysis on waiting times, and you can see it's not too bad. I've seen worse. We work in the NHS. But waiting on average anywhere from 3 to 9 hours. It's very similar in Australia. We have this thing called the 4-hour rule. EDs get funded based on how many patients get a disposition or a place to go within 4 hours. And I think this is one thing that non-clinicians don't really think about, but generally, like the average doctor wants to be productive. Like I go to work and I'm like, how many patients can I see in the ED today? I used to benchmark myself. Like how many people can I admit? How many surgeries can I do? How fast can I do the ward round? I don't know, maybe it's just like the ingrained competition of getting into medicine and like you just want to be productive. But you just get bogged down in the admin. Every time I see a patient, that's a set of work I have to do. I have to document what I did, I have to initiate orders, I have to call other doctors, I have to chase results. If this happens every visit, you just get kind of burdened by it all. That leads to burnout, clinicians leaving the workforce, people not wanting to go into workforce in the first place. And I think for patients, like how many times have you gone to see a doctor and this is the experience you get, And it's like, oh yeah, and then you're just like typing away. That's not really great medicine. Like most of the time from our research, we've done randomized control trials where we give Heidi to one group and we don't give it to another group. We actually find that the clinicians hallucinate more than Heidi. They make mistakes. They don't actually listen to the number of issues that the patients have, and they just get through less. And the patients on the quintuple aims, pretty much every measure gets improved if they're using an AI tool. So patients have better outcomes, they get through more issues, they have warmer, kinder care, make eye contact. The doctors like that because they don't have to type, they don't have to try to stay up with all the things that they need to document. The productivity of the health system goes up because the doctors are more productive, so they actually do get through more patients, which we'll talk about in a couple slides. But in EDs, like on average, if consultants have Heidi, they'll see 1 or 2 more patients a shift. And there aren't that many interventions that can drive that kind of overnight increase in productivity from a single tool. And that's actually completely unintegrated. Yes, we have to do governance, like privacy, train the staff, but essentially, you give them Heidi, they see 2 more patients within a week or 2. And this is across all of New Zealand. Every emergency physician has access to Heidi now. They did it in 6 weeks, completely unintegrated with any medical record system. And the productivity of the whole country has gone up by, I think, 10 or 15% in their emergencies. So it's kind of wild. Like, if you're looking for things to try to improve your hospital, there's literally nothing like it. And I think it's because when you hear AI scribe, it's like, oh, shoulder shrug. It's the thing that joins my Zoom meeting. But actually, yes, it is that. But for doctors, it's like the thing that causes us to not be productive. So let's free ourselves from the current system, just think about what the future looks like. So what I imagine is that a lot of the future will look like AIs like Heidi doing a lot of the stitching together of the health system, connecting old systems. You don't have to replace all of your different patient management systems, flow managers, medical records. AI can kind of sit across all of it, put the correct data in all the right places, essentially just listen in, transcribe conversations, every conversation, like your nurses, all your allied staff, your doctors, most of the interactions that happen for the patient, all captured, perfect. You get perfect data, basically, more or less, with some clinical review. And if I imagine the hospital, which is full of clinicians that are happy and that they're as productive as they possibly can be. Now, even more advanced would be once those patients leave into the community, Heidi, literally voice calling the patient or texting the patient, is actively managing that person's risk to be as low as it possibly can in the community. This is not far-fetched, so we already do this. In Northwestern, in the Northeast in the US, they have an endocrinology department that has a 10-month wait. So imagine your new diagnosis diabetes. You go to see this endocrinology department. They say, here you go, here's your insulin plan. Good luck out there. That's it. They literally cannot help you. You have to go see a primary care doctor and hopefully they can figure it out. So what we did was we created a phone line that they can call anytime, 24/7, that connects to the endocrinology residents, and they can asynchronously, so they don't have to be in front of the patient, but they review a backlog of those conversations and it's ranked by priority based on how concerning the conversations are. And that's live today. When I talk about capacity, that's what I mean. It's effectively kind of infinite in a way. We need chips and power, but beyond that, you can just have conversation with Heidi, get your history gathered. We reference guidelines, so we have really strong evidence-based guidelines that the attendings and consultants have reviewed and are happy with, and they've battle-tested every edge case and made sure they're happy with it, and then they set it live. And now they're far more productive. So they use that. One, their waiting list is going down because they're getting rid of a lot of appointments they don't need to have. And two, They spend the time seeing the patients that they actually really need to, that have really complex diabetes, that actually are most at risk of costing the health system money if they're risk-bearing, but also from a medical perspective, the most kind of complex, interesting cases that they train for. So yeah, I already spoke about this one quite a bit. I use this example because Commonwealth, we don't talk about the guys down south, and also how fast they did it. So whole country, all the EDs, 4 weeks, like incredible. And yes, you need the right product, you need support. The other thing here is that on the transcribing side, in New Zealand, they have a really big Maori population that speak te reo, which is has a lot of different cultural sensitivities. So we partnered with populations all around New Zealand, built a transcribing model that worked particularly well, and they've co-signed and we're happy with. And that's what I mean, like there's a way to do it. Like you have to be aware of these things and you have to actively partner with different community advocates, partner groups, Indigenous representatives. But the technology today is very doable. You can fine-tune models for almost any purpose. You just need the data set and you need partners to actually be able to build it and make it possible. But yeah, you can do it. So it's not just in New Zealand. So in Canada as well, we're in Michael Garron, similar kind of productivity uplift, roughly 2 or 3 patients per physician. And we've done quite a lot of work with the different OHTs and kind of all around Canada, but I won't bore you with too much time. So Yukon actually chose Heidi in a similar way, like Ken said, across all of their clinics. And yeah, had an amazing experience with them. And then over in the west, in Vancouver, in BC, they ran basically like a province-wide procurement. So they gave every organization 7 choices, so lots of different vendors. It was sort of like a pick your own and choose. And essentially, it's kind of wild. Like we basically got 60% of that group chose Heidi. So I think maybe I'm underselling the product a bit, but the really hard thing for everyone in the room is all these products look the same. So you click stop and it generates words. And no matter what the words are, non-clinicians are impressed. They're like, wow, this is amazing. But as the doctors, actually the exact way it writes is incredibly important. Every percentage point, like if you go from needing to edit 4% to 5%, you lose like 10% of active users. So the precision matters a lot. So we have like I think we call it voice, because surgeons like me write really dumb and annoying notes, like 3/12 instead of 3 months in words. And I know it sounds silly, but I had profs when I was first building the tool that would not use Heidi unless it wrote 3/12. Because they're like, well, this is not my notes. I'm not signing my name to it. This sucks. Like, just go away. So picking the right product matters. Basically, just test it with the doctors. That's the best way to do it. Just give them a few choices, see which one they like, and then just go with that one. Because back to this like hypothetical vision of everything transcribed, all the data going in magically, the thing that matters for that future to occur is whether or not the clinicians actually use it. They still have to click start. They still have to consent their patients. There's a tiny bit of friction, so they have to like it. And they ultimately have to sign their name to the notes and say, this is my work, which is really important. They do have to review it. It's not completely infallible. And so, yeah, the details of the product matter. And privacy is also super, super important. So I'll spend a little bit talking about this. Obviously, I could spend the whole talk talking about the pitfalls, risks, and opportunities here. But just generally, like if you're procuring a tool, these are the things I would look for. So 100% has to be stored, processed. All the models should be run in Canadian servers. Of course, there's all the different provincial requirements, which most of the vendors will satisfy. I think most importantly, you want to understand how is the data being used? Like, is there audio files being stored as part of their pipeline? Again, like easy to do a demo, very hard to do the engineering to make audio be like sort of processed in real time and not actually captured. It's a very hard engineering problem to do well. It's easy to do, but hard to make the tool accurate. And what are the secondary uses, terms, like what am I consenting the patient to? Like, am I giving them the whole medical record? This is literally the most sensitive thing. This is why privacy exists, like the conversation. So you need to have like a really high bar for whichever tool you pick. And they should have third-party verification like we do. So for all their encryption standards, storage, et cetera, they should have a trust center and have had someone else try to hack them and phish their staff and all that. So a little bit about sort of post-market surveillance. Again, how do you measure these tools? You know, sure, what else am I going to say? Of course I'm going to say it's great. How do you actually measure it? And this is for everyone in the room, this will be your job. So I think it's important to understand for where you work, what would be a good outcome. So the reason I focus on EDs is because it's easy to understand. Certain number of patients arrive, you need to get them to their destination, certain number of doctors, it's like a very clear, zero-sum environment. They either see more or less patients, easy to measure. If you're in an inpatient setting where there are many factors that dictate whether a patient gets home or not, what are the things that you care about? I don't actually know. Depends on, every organization will have their own set of incentives. Is it about how fast their discharge summary is created? Is it about their GP or primary care doctor getting a letter? Whatever those metrics are, just define them, know what they are, work with the vendor that you've chosen to make sure you're measuring them carefully. Then make sure that you're measuring and monitoring the performance of the tool. So we do this. So every time we generate a note, in parallel, I think it's the next slide. In parallel, we look at, are all the clinical terms that are in the transcript actually also in the note? So there's like a parallel kind of safety track that's looking at the transcript that we have, comparing it to the note, and actually grading, like, are there low-risk mistakes in the note? Are there high grade? Are there moderate grade? And flagging them to the clinician proactively to say, hey, like these things in the note, we couldn't find a good reference in the transcript, like you should definitely review them, and not letting them finalize the notes unless they've reviewed those checks, things like that. The other important thing about monitoring is, let's say there's a new model, or Heidi builds a new model, and we say, yeah, we want to roll it out at your institution. Then we can actually run it on the test set. So we can say, okay, let's do a test. We'll give half the population this new model, half keep the existing one. And we can say, look, this is actually more accurate on these metrics that we're tracking, rather than just kind of qualitative like vibes, oh yeah, it's better. Like actually check the data. Is it more accurate? Is there more or less hallucinations? How fast does it generate? What's the actual clinician activation? Like all the metrics that matter. And the reason we've gone deep on this is because we think over time these tools should be medical devices, and that's how we regulate in the UK. The reason is, so for scribing, it's probably okay. It's representing what they did and they were there for it, so that's fine. But if you're going into more trickier areas, like I said, calling patients, having conversations with patients unsupervised, or evidence where we're potentially influencing what a clinician's going to do with their patient, there needs to be a higher bar. Like it can't just be some tech bro. Like this is dangerous, and you need to prove that not only that you're reliable and that you're tracking how it's working, but that you're consistent. Like if you hit the button twice, it should perform the same way. And so I'm just going to talk a bit about product, show you more product. That's my favorite part. So I think if you think of this tool today as a scribe, I think ultimately it becomes a care partner. That's what we call it. So doing kind of every extension of me that I want a piece of software to do when I'm not looking. So it could be making sure my patient gets scheduled for their repeat appointment. It could be looking up guidelines for me based on the conversation. Every patient, I wish I could spend 3 hours thinking about the latest research and like what exactly should I do for them and what exactly is the right plan for them that I could just personalize for the kind of activity level they have and their weight and their age and whatever. I had this experience the other day. I was in an emergency with a family member, and I this is the worst. It's the worst being a doctor when someone's ill in your family, because you know what's going on. But in my head, I was like, I'm not quite sure. Like, it could be these 3 things I had in my mind. It was like appendicitis, maybe ovarian torsion, maybe something else. And I actually used Heidi. So we have a early evidence product, and I was asked it like, how likely is each of these conditions? And it found a study from the year before that had looked at that exact age demographic and done, I think, over like 10,000 patients, exactly the pre-test probability, which test to do, ultrasound or CT, and then the likelihood of the condition. And it was like, if I had this as a surgeon, I would just be a superhero. Like I would know exactly the percentage likelihood of everything, and I could explain that to my patient. But I didn't have it at the time, so I would just, again, like kind of guess. I'd be like, oh yeah, I think it could be these 3 things. Whereas I could have said that actually we do not need a CT, and with ultrasound, it's 95% likely that it's appendicitis, and it was appendicitis. Okay, this was one that you all think deeply about, integration. It's the automatic, you're a vendor, how do you integrate? How do you integrate? Don't even speak to me, I don't want to look at you. How do you integrate? Now, I totally agree. So clinicians don't want to sign into 2 things. You do need to do SSO, so you need to be able to sign in, you need to be able to verify that they are working at your institution and that it's safe and they're accessing data appropriately. This is all fine. But the key thing is that integration does not equal good. So you will get sold stuff from Oracle, Epic, Cerner is Oracle, lots of different medical record solutions. Overwhelmingly, our experience has been that, and it's similar to all the consumer AI tools that you all use, like Gemini, if you've ever generated an image, or ChatGPT or Claude. There's something like freeing about a new interface as the way that you use AI. Basically, all these systems of record were not built to be useful in an AI setting. So when they build it, they end up making like a form filler, is the way I describe it. Like it's like a thing that you transcribe and you click and it puts it in the fields. And yeah, that is useful, but there's a million other things that I want to use it for. Like I might want to create a patient summary. I might want to do what I just said, look up some evidence. I might want to generate parts of the note that are for an audit or for a registry or for something else. So it's sort of like an and. It's a Venn diagram that overlaps. There's stuff in the record that we need. There's stuff that we should put back in the record, but there are things that are useful that are not in the record that the clinicians will get a lot of productivity out of. So you don't want to pick the tool that's trapped inside the medical record. I bet anything that in 5 to 10 years, everyone will be using something like Heidi or competitors that are freed from the record. A good example is the call stuff. Like, where do I put the transcript in the record? Why would they ever build that? Maybe scheduling, I guess, but like very hard, doesn't really belong, kind of this like scary general open space. So there's sort of lines in the sand where they just won't build it. And I think that's actually where all the capacity is going to come from. So again, what else am I going to say? But I would generally say pick a partner that actually has a broader ambition than filling the 4 fields that the doctor needs to fill in front of them. We already do this today as well, so back to where does this all go? So when you generate a note on Heidi, we can show you outside, you click stop, we generate a set of tasks. So all the things that the clinician needs to do next. So orders, coordination steps, any documentation they need to do, and some of them we already have a single button they can click that automatically, magically does it for them. But the idea is that you review the tasks, you say, sure, go do it, Heidi, on to the next patient. So more and more, like our job is to tick off those tasks, figure out what they are, and then make sure that we can go do them. And yeah, I think where this all ends up is basically Heidi slowly has more autonomy, very slowly. So I might be here in like a decade or with a walking cane talking about how Heidi might maybe one day do some prescribing. So it doesn't have to get to the most advanced, most autonomous to be useful. I think it can be very useful in the visit, figuring out the tasks, like what are the things that you have to do next, trying to do a lot of them, so drafting the order, putting in the registry information, creating the audit, all these things are easy to do, helping the patient coordinate through the system, scheduling, etc. And then I think over time, this is back to becoming a device. We'll do more and more supervised things. Again, even in the most advanced, still fundamentally supervised, like a kind of colleague, I think, is the best way to think of it. Doing things like triaging, maybe monitoring patients, doing investigations autonomously. I can imagine certain workflows where you build these things. And yeah, I think there's videos, but I don't know if they work, but that's okay. Oh yeah, I've got to click next. So this is what it looks like. So you generate the notes and then you see the tasks on the right-hand side. And similar kind of thing with evidence. This is how it works. Don't know if we got the answer, damn. Anyway, so at the end of the thinking, you'll see all the sources, all the referencing, everything that it's thought about, sometimes hundreds of sources. So effectively sort of doing doing what the clinician might if they had infinite time to do research on the case that was in front of them. And calls and a few other things. So yeah, I think fundamentally, doesn't have to be us. Just give your clinicians these tools. It's incredible. They will love you forever. Just do it. The second thing is try to pick one that has the ambition to go further than just notes. I think it's quite important. And yeah, thanks for having me.
Have time for maybe one or two quick questions? Go ahead.
Hi there. I saw a quote on one of the slides that a doctor appreciated the tool because it allowed him to translate his note for a patient that didn't speak the same language. And I'm just wondering, do you know how widely the tool is used to provide the information back to the patient? And the second question is, at the beginning of your talk, I heard you talking about somehow using the data generated by Heidi to assess bedside manner. And I'm wondering, like, if you can speak more about the potential for the tool to coach physicians that are speaking to their patients.
Yeah, thank you. Yeah, so for, oh my God, my brain, I forgot your first question. Translation,
Back to the
translation,
patient.
yes, sorry.
Or even if it's not translated, just giving them the information.
So yeah, you can pin documents. So by default, we try to encourage clinicians to create a patient summary. So yeah, it can kind of auto-magically create a summary, even for their level. That's my favorite one. So we have geneticists that use Heidi, and they will have different age buckets. And so you know, like if you have some devastating genetic diagnosis and it's a 7-year-old, like what do you give them? And like usually there'd be nothing basically today. So they'll instantly generate like a story, a Taylor Swift song, a whatever, to explain the situation. So yeah, definitely like giving back and that's a key way to describe it. Like, you know, are you happy with me using this tool? It means I don't have to type, and I'll show you what it's written, and I'll give you a summary at the end. That's like the best way to describe it.
So we have a question online. What data is used to train the model for the AI scribe?
Yeah, so generally we use large foundation models, so it's the same as everyone else. So basically like whole internet, effectively. So there's lots of vendors like Gemini, OpenAI, Claude, etc. Actually at Heidi, we have our own models. So we use user input, so we don't use PHI, just to be like incredibly clear. No patient information in our terms. We're not allowed to use notes. We don't have access to them. But what we can do is show 2 notes and say, which do you prefer? So that's an example of user input. So all we're doing is getting like signal of like which of the notes do they like better. So that's an example of user input feedback. And then we do reinforcement. So basically for a million reasons, like to the New Zealand example, like how do you get Heidi to get all of the little idiosyncrasies of te reo in NZ, which is, you know, there's literally not on the internet. So we start with a base, and then with a population that we're working with, with consent, we say, okay, we're going to show you 2 options. Just tell us which one's better, which one's more accurate. And you do that like 2.5 million times a week, and you make a model, basically. Yeah, so that's generally how it's done. I think sometimes everyone in this room will think of data science approaches where it's like you have all the data stored and you create your own neural nets that learn certain characteristics or identify patients. It's actually kind of different. It's like you're starting with a brain in the shape of these foundation models that knows a lot of stuff, but maybe not your topics exactly, and you kind of like steering it towards your task. Hope that makes sense. Also, your question about how do you get data back, just going back a step. So this is a few ways, but so we have a whole like developer docs API schema where you can create structured data, like with actual fields, so like a JSON for those that know. So if you have a drop-down or radio button or multiple choice or short or long text, you can define that in the structure. And then when you click stop, Heidi will generate that JSON and send it back wherever you want it. And you can do multiple at once. So you could have like a registry and patient flow at EMR and somewhere else, all on stop. Even stuff the doctor doesn't see. Yeah. Okay.
Hey,
Thank you.
I have a million questions, but I'll catch you during networking. Just
jump?
very,
Sure.
yeah, go ahead. Just quickly, like what if I were to say to Heidi, make me sound more professorial or, I fear with all these AI language tools that we're going to have a generation of doctors who can't write a paragraph anymore. Just my comment.
Yeah, so I was just at a few medical schools over the last week or so, kind of explaining how to use it. So I think it's important that you teach them, it's going to be there once they practice, but what we actually do is, so we have registrar, resident, intern, student programs where it's two ways. So one is the templates. So you can force them to use templates that does not help them. So basically only recreates what they said. You can also create templates that will give them feedback. So areas back to bedside manner. You can set up a guideline and say, hey, here's where you should have been nicer. And then another one is nicer. Yeah. You should actually think about feelings. And then if you click, you can make it so that it doesn't generate instantly. So we have an area where they can write their own note, basically. So there's ways to do it, I think. Yeah.
Clearly. Okay, so thank you very
Thank
much.
you. No worries.
And Heidi does have a booth at the exhibitor lounge, so we're coming up to a break. I'm going to ask everyone to come back at 3:55 because we need to fill out a survey.